So in abortions, so you have to start with, as I said, any childbearing age, a female came to you, you have to start with beta HCG. She has abdominal pain, she has irregular periods, whatsoever she is having, and she is a female, she is childbearing age, like after 18. And if this success, like specifically mentioned that she is sexually active, then they are actually looking for beta HCG. Then we are going to do the abortions. So there is no like if some female wants to go for abortion even at third trimester, I mentioned that you can go for the abortions. You have to respect her wishes. You can always start with counseling, but in the end of the day, whatever she wants will go with that. So you have to see in the option if there is anything like counseling, in the like talking, uh, telling them like a conversation kind of thing, wherever it is you have like a talking, then in those cases you have to choose that one. But if there is no psych counseling, there isn't anything like that, and they're asking for respect the patient wishes, in those cases you have to go for that one. Now there are different types of abortion. A threatened one, inevitable, incomplete, complete, missed, recurrent, and septic. They do ask a lot of questions to make the diagnosis of this one, and they can give you the clinical and ultrasounding findings. A patient came to you with bleeding, she has cervix closed, and the fetus is live on the ultrasound. What is the type of, or what is this abortion? How will you deal with this case? So in threatened case, the cervix is closed, it's just a threat. So nothing happened to the fetus, nothing came out. So in that case, just watch and wait. And in many less cases, they go for abortion. Otherwise, it's there. Then inevitable bleeding and cramping. In that case, is fetus low in the uterus, cervix open, but baby did not came out. So you have to watch and wait. If the baby is not alive, or sorry, the fetus is not alive, in those cases, putting the misoprostol and they will come out. In many worst case scenario, going for dilation and curettage. Complete one, everything already out. So cervix is closed, no bleeding on ultrasound, everything is fine. So no management needed. In incomplete, half of the tissue is out, half of the tissue is in. The cervix will be open. So many times we do miss out the incomplete and inevitable. In those cases, you have to see, in both cases the cramps are there, the bleeding is there. The cervix is open. Sometimes they do mention there is a residual tissue, sometimes they don't mention. So in that cases, you have to see if they are talking about like the fetus, if it's out in if they're not talking about the residual tissue, they will definitely talk about the fetus. If it's low in uterus and they talk about the residual tissue. In that cases, they're talking about the inevitable, or they mention about the fetus somehow, and they say the cervix is open. In that cases, it means this is inevitable. But if they did not mention a fetus, but they're talking about a tissue, so usually they regards the fetus as a tissue in incomplete, but in inevitable, they do mention the word fetus. So that will how you get the idea that they are talking about which one. So in that case, we do watch and wait and misoprostol and dilation and curettage in the worst case scenarios. Then the missed, in those ones, there is nothing. So the baby, the fetus is already dead, no heart rate, nothing, but the cervix is closed and the fetus is inside the uterus. So in that case, is what do we do is watch and wait and mifepristone followed by misoprostol. So in missed one, you have to start with opening the cervix. That's why we go for mifepristone. So if they ask for the cervix is closed and you have to start the abortion, so the answer is mifepristone. But if the cervix is open and now you have to continue with the rest of them, then the answer is misoprostol. So kindly look into the words what they are giving you. Then the recurrent, if it keep on happening, in those cases we go for the further monitoring, doing APS and all of those testing. Then the septic one. Septic one is very, very rare, but usually in those cases we have to start the IV antibiotics, then going for anything else. Embryonic demise can be diagnosed by ultrasound. So if for your case, the septic abortion, in those cases, we don't go for IUS. Like after doing septic abortion, like we did manage and everything, in those cases, we cannot go for IUS right away, intrauterine devices, as a contraceptive. Okay. Then embryonic demise can be diagnosed by ultrasound. Usually we check for the gestation sac, round drum length, and the no cardiac activity. Then comes the ectopic pregnancy, one of the very common topic, and usually they like to ask where is the common site where there is the the ectopic pregnancy happens. So it's basically the ampullary one, and like rest of them are isthmus and then fimbriae. So mainly is the ampullary one. So in that case is how you're going to start with beta HCG, and we go with along with serial beta HCG. Then abdominal pain and bleeding will be there. So we do check if there is a hemodynamically stable, if this is a hemodynamically not stable. So what you need to remember here is if it presented in an emergency case, it will be a different diagnosis or you will have manage them in a different way. Then in the other case scenario, usually we go for the if they are not hemodynamically stable. So in that cases, we go for different thing. So if they're talking about hemodynamically stable, in those cases, going for transvaginal ultrasound, serum beta HCG. If they are hemodynamically unstable, in those cases, going for surgery right away, giving transfusion, ROGAM, all of that, packed volume. So going for everything. Now we are talking about hemodynamically stable, so you have to do transvaginal ultrasound in those cases to confirm that it is already outside or inside. Okay, although we did beta HCG and beta HCG is crazy high, we do have an understanding of ectopic pregnancy, but still, if it's a stable and you have a chance to do ultrasound, in those cases, we go for ultrasound. So keep that in your head that stable patient, even doing for beta HCG, we go for ultrasound. Then in those cases, if there's a intrauterine pregnancy, we follow along with that. If not, then we always check for beta HCG. If it's declining, increasing, how is it going on? Fetal heart rate is there or not? What about the sac? What about if there is any chances of ectopic pregnancy? Then according to that, we follow the management. But if there is no fetal heart rate, ectopic pregnancy is confirmed, then there is no, like, all of that contraindications of methotrexate, then in those cases, we go for methotrexate and patient does not meet the criteria of medical or contraindication. So in those ones, we go for surgery. Now, how I remember the contraindications of methotrexate, usually methotrexate affects all body organs. I don't think so there is anything that does not affect blood. So you can see hemodynamically instability, we don't go for that. Hepatic, renal, immunodeficiency, lungs, stomach, liver, heterotopic pregnancy, hypersensitivity, breastfeeding. So overall, if you think of whatever is there that could cause bleeding, or that has immunodeficiency. In those cases, we don't go for methotrexate. I believe everything has something like that. So in those cases, we don't go for methotrexate if someone has any of those things. So mainly three things you have to think of: hepatic, renal, and hematological. Then you can remember other things as well. Then comes to the risk factors. If there is a previous history of ectopic pregnancy, in the next one, you have to think of ectopic pregnancy. I keep telling you previous history is very, very important in gynecology. Then the current IUDs, PID, infertility treatment, IVF is very, very something these days going on. Then the previous procedures, smoking, structural leiomyomas, and adhesions. Then the lower abdominal pain, urinary tract, UTIs, GI, gynecological. So all of those ones depending on where the pain is. Any woman presenting with abdominal pain, bleeding, and amenorrhea, you have to think of ectopic pregnancy as they say is until proven otherwise. Okay, so in Toronto notes, wherever the word is until proven otherwise, those statements are very, very important. Keep it in your head because those are clinical diagnosis. If there are three symptoms, we are going to this is basically that one, and that's how we do practice in our hospitals as well. Like, if a patient, like I recently saw a patient which was having pain, bleeding, amenorrhea, and she was hemodynamically unstable, we did not even get the chance to do beta HCG. We just decided this is an ectopic pregnancy and we started the management according to that, calling for gynae and all of those surgery preparation. So there could be scenarios where there are like things like that. So if there is an until proven otherwise, these statements are likely to be tested in exams a lot. Okay. Then this thing here, they do ask what is the investigation. So as I told you, we do beta HCG, but the answer is not beta HCG, it's the serial beta HCG because we have to keep checking it in every 48 hours in the first 8 week and then checking in over the time again and again. So prolonged but doubling time or decreasing. So in those cases, we do check for that one. So if there is an abnormal doubling time, it's a higher chances of having ectopic pregnancy. Then obviously the ultrasound, wherever you get the chance of doing ultrasound, finding on the transvaginal ultrasound is a tubal ring. Then empty uterus is one of the finding that can help you to figure out, and along with beta hCG more than 2000. Then laparoscopy is basically the definitive diagnosis. So if they ask for definitive diagnosis, don't go for beta hCG or ultrasound, although we do those things preferably, but definitive diagnosis is basically this one. Then the treatment is basically starting with if this is a hemodynamically stable case and how you're going to stable that one. And they don't say this is a hemodynamically stable case. They will give you BP, heart rate, emergency case presentation. So in that cases, you do decide that you are going for surgery or medical. And believe me, in QE1 exams, they do like to assess if you are able to make a decision about surgery or not. Then comes to the surgery. In that one is basically linear salpingostomy. If someone wants to conceive further, keeping the fallopian tube preserved, and don't forget about this one, sorry, ROGAM. Patient may require the laparotomy if unstable and if there is having too much bleeding. Then comes the methotrexate. So you have to rule out all of the side effects of the methotrexate, and then we're going to give that one. Follow beta HCG on the day 4 and 7, like have every 48 hours after injection, and weekly until beta HCG is not detectable. Administer a second case if the beta HCG does not decrease. Then tubal patency, prenatal vitamins like folic acid should be given, but it will decrease the efficacy of methotrexate. So when you are giving methotrexate, you have to stop folic acid. Then comes the infertility. We have seen so many cases these days. That's why I believe they will do a lot of testing from infertility. I don't know. Recently, I have seen so many cases like 43-year-old female coming for the first time, 45-year-old female coming for the first time. And I don't know why 45-year-old she's never did any for infertility treatment before, and now she's doing it. Maybe these days government is providing IVF or whatever is going on. So there's so many infertility cases that is in coming to regular daily practice. So the most important factor is the age. But in the end, again, so we were recently dealing with this case, and then we were thinking that the female was 35 and the male was little bit younger than that. So we did not get a chance of thinking of anything for the male, and we were, I was doing the test for female until I was like sitting down, and I had a very thorough discussion with the couple, and then asked them, how about we do a semen analysis for them? And then after doing the semen analysis, we get to know that there was a problem with semen, not with the female. So just for your idea, that's why you have to start with the semen before starting with the female as well. Because although the age is, she like the male age was good and the female was little bit older, like in her 40s, but still we were considering that maybe the age factor in the female was the considerable factor. But the other part you have to see that too. Then chemotherapy, ovulatory functions like hypothalamic stress, poor diet and excessive exercise, for pituitary, ovarian PCOS, primary ovarian insufficiency, luteal phase, then systemic, and then congenital could be tubal problems, PID could be there, adhesions, occlusions, uterine factors. Then comes the cervical factors, endometriosis, multiple factors, and unknown cases. Now we are talking about infertility. Then there's the primary infertility and secondary infertility. So in cases like, where a female is 45 and we are not able to sure what is going on here, and there is no, like, in those cases, which is like above 35 or above 38, usually we don't waste our time doing any testing in clinic. We just refer them to infertility clinic. So there is some infertility clinic like things, then they follow up along with that. So in those cases, we just refer them to there. So just for your understanding, I'm letting you know, if they give you any scenario where they're asking you if she's 35, like, mainly the age factor is one of the most considerable factor, then you have to think of, what are you going to do first. So infertility is basically inability to conceive, and then primary infertility and then secondary infertility. So primary infertility, never conceived before. Secondary infertility, you have to check for female and the male before as well. Mainly we check for the male one, and then female comes the second one. Then infertility is the context for the prior conception was there, but this time they're not able to conceive. When should investigation begin? Less than 35. So usually after 1 year after regular unprotected intercourse, so we have to wait for 1 year. 35 to 40, we do wait for 6 months, and then after 40, we do refer immediately right away. So in our cases, after 30, 35, we do start the investigations. But obviously, the referral part usually we start after 35. So hopefully, when you guys are going to start working too, so you will see even maybe by the time you will start, we'll just start referring by 30 or maybe 35. Then earlier, if the history of PID, history of infertility, prior pelvic surgery, chemotherapy, and then pregnancy loss, so endometriosis could be there. So I recently saw cases where she just got treatment for endometriosis and now she's going for, so what happened, she got endometriosis and her endometriosis was in fallopian tube. So they removed the scar tissue from endometriosis, but what they do, they ended up tying her fallopian tube. So now both of her fallopian tube is tied up and then endometriosis is removed and now uterus is okay. So she now wanted to go for IVF, but at the same time, she wanted to untie her fallopian tube. So it's kind of very critical thinking. So I keep her counseling about that part. If we open the fallopian tube, she might have get chances of having ectopic pregnancy and all of that. But she still wants, oh, I want to get back to normal. I'm not normal now and all that. So it was a very like ethically challenged question. So in this kind of questions can be asked in the exam as well, like female is like this, so what are you going to do? So mainly we do counseling, but let's suppose if the end of the day she wanted to do it, so I ended up referring her to an obgyn so she can get a second opinion from them. Okay, so this is how it works here. Then cervical factors, these are mucus, anti-sperm antibodies, then structural one, endometriosis, multiple myeloma. So you have to remember which one is 20 to 30% at least. So the biggest factor is the age factor. Then if we go here, the most important is the endometriosis, multiple factors. Then tubal factors like PID, adhesions, those are the 30% one. Then slowly the 20% is basically outflow obstruction and then unknown causes. Then the other factors is 5%. If you could actually forget them or skip them, it's fine. At least you need to remember the most important one, like the age factor, endometriosis, PID, infection. In those cases, it's very, very common. Okay. Then how you going to do that is the day 3, we do test for FSH, LH, estradiol, thyroid, prolactin, so all kind of hormones we do test in the day 3. But the progesterone we do check on the 21 to 23 day. General checkup is basically CBC, iron, HbA1c. Then we do for HSG or sonohistogram, like those one, then laparoscopy, and then all of those one together to find out what's going on. In worst case scenario, we do check for the anti-Mullerian hormone. Usually it's being tested by a gynecologist. A rest of the ovarian reserve, the higher the number, the better it is. So then the treatment is lifestyle changes, asking them to not stress, although they're going to do stress, but still smoking, cannabis, caffeine, alcohol, diet, exercise, all of that. Then education purpose, have sex every other day for 2 days and all that. So then ovulation induction, in that one, you need to remember the name of the drug which is helps with the ovulation induction. Which one is that one? Clomiphene citrate and letrozole. So there was another day a female was calling that she wanted to get clomiphene citrate. So I was ended up telling her what are the consequences and what are the side effects. So they will keep on asking you what are the side effects and all of that one for clomiphene citrate and letrozole, and how does it work for them. So because it induces the ovulation, so you have to be very careful of that one. And yeah, followed by beta hcg for the ovum release. Then may add the bromocryptine as well, metformin, luteal phase, progesterone, anticoagulation, and then thyroid. Then the surgical is tubuloplasty, removing the adhesions, all of such insemination, IVF, gift, and all of this one. So you could remember these ones. Then comes the male factor. You need to remember the male factors too. And the most important ones is given in urology. So varicocele is the most common factor. Then the other ones is idiopathic obstruction, cryptorchidism. So I just recently saw a case. That's why I'm discussing this one. There was a female who, sorry, not female. There was a male who just presented. He's like 18 years old male, and he presented with he is having pain in his groin area which is radiating towards his testicles. And when we did the test for his testicles, the light was passing through, there was no obstruction, and he was not having any pain on like palpation. There was no hernia, nothing at all. And when we asked about his work, he was working in some place where he has like a prolonged standing, like maybe 12 hours standing, and he's wearing some tight clothes. So that's how we ended up getting that he just need reassurance. So every kind of case, obviously it was giving a little bit of idea that maybe he's having a testicular torsion or varicocele. That's why we did all the examination part, but we did not do any investigations for that person. Although he was like, oh, can I do the ultrasound? I want to do this and that. When we did everything, we ended up getting finding nothing. So in that case, the answer was only reassurance. But he wants to do an ultrasound. So I told him, try to do the job modification. But if it did not work out, in those cases, we go for ultrasound. So you have to see in the scenario if they have given everything, but the examination point of view, everything is negative. So you have to be very careful in reassurance part. Although there are many cases where we do have to do reassurance, but in many cases, if you don't feel comfortable and all that, so in that cases, you can go for the investigations. But in the same time, if they mention that the light test is negative, no palpation, no redness, nothing at all, so in that cases, you can go for the reassurance. And there, believe me, there are many scenarios where the answer is reassurance or no investigation or clinical diagnosis or something like that. Then normal semen analysis. So these are the normal one. Volume is 1.5 count and this one. So this one. Then semen analysis and culture we do just for that one. Then comes the PCOS. In PCOS, always think of the what is the most common hormone that we test in this one. That's the concerning point. And then it has the Rotterdam's criteria. 2 out of 3 criteria: oligomenorrhea, hyperandrogenism, which is basically clinical evidence, and then biophysical evidence, then polycystic ovaries on the ultrasound, which is not appropriate in adolescence, but usually it's a very later on stage. So with hirsutism, acne, we do think of a PCOS. Average is 15 to 23 in adolescent, wait at least 1 to 2 years, then irregular periods, acanthosis nigricans, then insulin and diabetes is one of the most concerning thing along with that. So PCOS can be confused with what? Cushing syndrome, ovarian neoplasm, prolactinoma, and hypothyroidism. Mainly it's confused with hypothyroidism. I see many cases where we do get confused with between these two. What are the clinical signs where the endocrine imbalance? Usually many females, even a thyroid, if it's a whatever it is, the main presentation is their menstrual cycle, then infertility, hirsutism, obesity, and then intolerance, and then diabetes. How do you start with that? BMI, BP, fasting lipid profile, then goal is the hyperandrogenism and checking for the ovulation. Then we start with the prolactin, thyroid, T4. Obviously we have to rule out everything. Now, when we are talking about this one, which hormone do we test for that one? So I usually saw we do go for LH, luteinizing hormone, but for your just knowledge, the answer is always the free testosterone, because the free testosterone is more sensitive than LH. Although we go for LH and FSH and compare that if LH is more than FSH, but in our practice, like these days, what we are doing, we do test for that testosterone right away in females. And the previous doctor, they're like, why are you going for testosterone? Then we have to tell them this is more sensitive than the other one. So in those cases, you have to be see, and because they ask you or question you back, why are you going for testosterone? So then the hydroprogesterone, LS, FSH, DHEAS, androstenedione, and then free testosterone. Then the transvaginal and transabdominal ultrasound checking for the cyst. Then the test for the insulin sensitivity, OGTT, and then endometrial biopsy, and then abnormal bleeding checking for the causes of that one. How do you start with that? Obviously, the first factor is their weight gain, their acne. So you have to talk about everything. So weight, lifestyle modification will help them a lot. Then hormonal intrauterine, oral hypoglycemic drugs, tranexamic acid for bleeding. Infertility, you have to start which one? Clomiphene citrate and letrozole, or the human gonadotropin hormone. Metformin can be used as the thing. Then ovarian drilling is one of the most important one. Then comes the most important thing, their hirsutism. Okay, if a female is not having any symptoms, not having any problems, like no bleeding issue, no irregular periods, but she is having hirsutism. Now a straightforward question come from only hirsutism. Although it's making sense to yet it is OCPs or anything like that. Sorry, it is PCOS. But they are just asking you about how you will manage the hirsutism. Or she's concerned about hirsutism, how you're going to start with that. So usually we do start with OCPs, but then you have to tell them which OCPs, how, whatever, the gain part, weight gain part, acne part, and all of that. Then If not for the OCPs, they don't want to go for the OCPs, then in those cases, going for a mechanical removal. If they don't want to go for something on their face, like no radiations and stuff, then finasteride, spironolactone, that usually works really good. And finasteride, I have done. I haven't used any flutamide, so I'm not sure about that part. But yeah, the finasteride and spironolactone usually works really well. So you have to start with OCPs, then you have to counsel about that. Usually, female do agree with OCPs like Deanne, Yasmin, but then you have to tell them about weight gain, acne, and all of these things. Then going for the removal part, like a mechanical removal, then spironolactone and finasteride, because spironolactone and finasteride has their other side effects too. So they do call baldness and all of that. So and then blood pressure problems too. So in that cases, you have to look out for those ones too. Um, then we are talking, next thing is gynecological infection. In this one, the main important here is you need to know which one is normal vaginal discharge. And in those cases, just or regular simple reassurance. Do this one is important, okay? Because female came to you with a white clear discharge. Don't think that this is a yeast infection or any other kind of infection. Okay. So this is a very clear white discharge. There is epithelial cells, and in female, it's very common. So you have to do is simple reassurance. If they are not having itchiness, no, nothing, no pain, nothing at all, and they are having it for the first time, or in the 14, 15-year-old female, she's coming to you, in that case, it's just a physiological response. Then comes the vulvovaginitis. In this one, there is an irritation, and this is very, very common in females too. Irritation, pruritus, discharge, vulvar erythema, and then vaginal bleeding is there. This is mainly caused by the group A streptococcus, lack of all of those pH, because usually they're using some sanitary. So if you ask a very proper question, a very good history, if your history is very good, you will ended up finding that she is using any cleaners. So let's suppose if she comes to you and then or maybe a question comes to you like she is using she's going to school and someone in the school told her to use any sanitary or vaginal wash or something like that, and she's using it and regularly, but she's having a lot of what is this, the itchiness, and there is bleeding, minor bleeding, and then there is discharge coming out. So if they did not mention, but in those cases, she's like, oh, she used it, or she's going into school, but they did not mention what is she doing, and she's having only discharge. So it's mainly, the teenage girls do like to start any kind of like, cleaners and sprays and powders, and it is the one of the most common one. So that's why they say in the side one. So wipe front to the back. That's many important question how you counsel the female so they don't get it in future. I mean, we do get the treatment now, but there is something they ask very mainly like how do you deal with it in the future? What are you counsel them in the future? So front to back, wash vulva only with water. Then avoid daily panty liners, avoid douching or using any sprays, cleaners, powders. So you have to mention even if she says in her history that she is not using it. Then the laundry detergents for the underwears, and then cotton underwear, no underwear at the night time. So like, or maybe you can say no underwear at home. So then on the side, you can say the poor hygiene is most important. Then foreign body could be there, and especially in the teenager, it's very common. Then the skin disorders, then trauma, pinworms, candida, and then don't forget about the pinworms. Pinworms do causes a lot of itchiness too, but it's usually in the anal area, and they do mix it with the vulvar area. Candida, and then group A streptococcus, discovery of STIs and all of those tumors, polyps, and all of that. In those cases, going for the vaginal swab for the culture, then pH wet mount or KOH smear, and then treatment. And in these days, we do ask them to do a self swab. Self swab is telling them how to take a self vaginal swab. So in those cases where she's not comfortable, in those cases, we give them the all the instruments and they do it by themselves. Then comes the treatment, enhanced hygiene and the local measures. Like we do talk about all of those ones. So avoid this, avoid that to protect the vulvar skin. And then if they ask, okay, I'm having itchiness, then what should I use? In those cases, you can ask them to use only Vaseline. That can be helpful. Then the infections treat with antibiotics of the organism, whichever is their most common gynecological problem in the prepubertal, in the non-specific, this one. Then comes the preparator, how you're going to the ethic point of view. Clinicians who treat obstetric adolescents must be aware of the federal, state, and the provincial laws. Keep consent and confidentiality. Clinicians must be aware of guideline governing funding resources for the particular services and be familiar with the consent and confidentiality policies of the facility in which they practice. So recently I learned something new about the confidentiality. Like if you are working in a hospital and you saw your brother, okay? So usually like you saw your family member or something like that, and they did not see you. In that case, is what will you do? Obviously you're not going to go them and talk about or ask them what they are doing here. That's called confidentiality. And in one case scenario, let's suppose if you see them and they see you back, I'm just giving you an example so you understand what confidentiality is about in Canada. So now you see them, they see you back. In those cases, and he comes up to you and asks, see you. In those cases, you what can you do? So in that cases, you have to obviously he's talking to you, then you have to talk to him back. But you cannot ask, why are you here? What are you doing here? And all that. Then comes another scenario where your brother or your whatever your family member is there, and you are talking to him, and he's talking back to you, and now he asks you, can you help me take me to the X-ray department? What will you do in that case? You will take him to the X-ray. So saying no here. So if you can understand here part, obviously we are talking about confidentiality. You don't want to get involved with his care, but at the same time you have to help him. So if he asks you to take to the X-ray department, you will take him to the X-ray department, but what will you do? You will not go further than that. You will not ask him what he wants, why he wants, or in X-ray department, what is his whatever thing he wanted to do. So you will just help him to reach the X-ray department and then say goodbye to him. And then when you are at home, you are not supposed to talk again about that unless he opens up and says something. In that cases, you can listen. Okay. So I'm helping you to understand what confidentiality, and these are the questions that can be asked in the exam where they do like to just test your confidentiality. And this confidentiality can be asked in your interviews, in your Gynecology exam, anywhere, everywhere. Okay. Then going down, so you can see the pin bombs is basically cellophane tapes. We do what is that? The treatment mebendazole, lichen sclerosis. Please see how does the lichen sclerosis and lichen planus look like. They have same similar name and they are very confused. I mean, I do get confused between them. So please do see the picture of them. Well, how does the lichen planus looks like, and what is the difference between lichen planus between the lichen sclerosis? Then we are talking about the candidiasis and vaginal bacterial vaginosis and then trichomonas. Uh, we do so many cases. Like if I'm doing an OPD or maybe I'm sitting in a clinic, like out of 10 patients, 5 or 7 is from candidiasis or UTIs. So that's why this is one of the most important topic, and they do like to test this one. So in the patient who is diabetes, AIDS, antibiotic use is very common. And one more thing, estrogen level is high, or the pregnant OCPs, whatever those, they do get involved with the candidal infection. They do have white cotton cheesy discharge. In that cases, you have to see where the itching is. Okay, I'm talking about if the given exam scenario, this says that she is having a vaginal itchiness, or she's having itchiness in the private area, or she's having itchiness on the vaginal area. So in that cases, you have to see if it's inside or if it's outside. If it's inside, it's different. If it's outside, it's different. Okay. And the treatment is different as well. So then comes to the intense pruritus, swollen, inflamed genitals, then vulvar burning, dysuria, dyspareunia. So dysuria could be along with this one. Don't go for UTI. So even if they give you a scenario with dysuria, so your DDs or differential diagnosis, you should keep the candidiasis as well. We do forget about this one. Then we do the KOH mount test, checking for the hyphae and the spores. We do give the clotrimazole. Clotrimazole is for the female who have the vaginal itchiness outside. And then, Canesten or whatever the other, there is special vaginal cream that goes for the inside one. So you have to see which one you are giving. But here, obviously, you are talking about this one. So in this case scenario, we go for the both of them. So the answer is clotrimazole or miconazole. For 1 to 3 or 7 day treatment, or with only vaginal treatment in the pregnancy. So those are the fluconazole per oral in single dose. So diflucan the tablet name. So we usually give the fluconazole only one tablet for the pregnancy female. Even we go for the worst case scenario where she has using the cletrimazole for too long and she's not getting better. In those cases, we do give them diflucon, like the fluconazole one tablet and just a single dose. Then comes the side one, the bacterial vaginosis. That one, they has a fishy odor. Then comes the vulvar and the vaginal irritation. This one is basically it causes the preterm labor. So you have to treat this one non-symptomatic pregnant female, even if the female is pregnant and she's non-symptomatic. In those cases, we do treat them. But if there is no treatment, if non-pregnant and non-symptomatic, no symptom, non-pregnant, no treatment. Simple. If pregnant, in those cases, we go do for treatment. Unless scheduled for the pelvic surgery, in those cases, we give the metronidazole. Only treatment is best for the pregnancy. So keep it in your head. If the female, she is asymptomatic, she is pregnant, any kind of treatment we do, like any kind of infection, we do give the treatment. And then the answer is metronidazole. Usually we give those ones, and then I'm offering them the probiotics. If someone is very, very disturbed, ask you, oh, it's happening to me over and over again, what should I do? In those cases, you have to tell them about the probiotics, and along with that, the vulvar hygiene, whatever the thing is. So I was focusing on this part. If the preterm labor is very, very common in this one. Preterm labor could be there, preterm birth, postpartum endometriosis, and those ones. Then comes the other one, the trichomonas. Trichomonas is usually the one that gets sexually transmitted. So treat even the asymptomatic one. So as you can see, in this cases, we go for asymptomatic treatment, and the answer is metronidazole. Then the motile flagellated organism, many WBCs and then inflammatory cells are there, and the positive whiff test. So check for the strawberry cervix. In this one, the strawberry cervix is there. In this one, there is a yellow-green discharge. Along with that, sometimes female do present with vaginal spotting, although it's not written here because they have petechiae. So they do get with the vaginal spotting. So spotting is also if they give you a discharge, malodorous, whatever, and you are not able to make any difference between the vaginal bacterial vaginosis and then trichomonas. In trichomonas, usually there is spotting, like the bleeding. So don't confuse yourself. If they say bleeding, then don't go for the other ones too. Then comes the chlamydia and gonorrhea. So wherever we are talking about chlamydia, we have to treat the gonorrhea as well. So in those cases, it's basically 80% asymptomatic. Usually in Canada, how do we practice this? If someone is coming to you and she said she just recently got exposed to a partner where she feels that she or he is having the chlamydia and gonorrhea, we usually give them the treatment. And we do have tablets in the clinic, and we just give them and ask them to take it right in front of us. Okay. So, and then we fill up a chart or form that they take the chlamydia and gonorrhea treatment and send it to the public health. So asymptomatic mucopurulent discharge, urethral nemesis, dysuria, pyuria, and frequency, pelvic pain, postcoital bleeding, and then sexual partner. How do we do is basically cervical culture. Usually we do the blood test. I don't know when do we do cervical culture and all that NAT test. So usually we do the blood test and we just send them that one. But here this says the cervical is the one that we do for the and the NAT test, what it's called. Urine or the self-vaginal test are now available, as I told you how to do that one. Then the STI test is basically you can test from the vaginal swab, test for the bacterial vaginosis, trichomonas, cervical swab, and then testing for the gonorrhea and chlamydia. So treatment is doxycycline, and then usually we give them doxycycline and cefixime both together. So this is doxycycline or the azithromycin in a single dose, reportable disease. Even we do treat them, they're not positive, we do report them. Wherever you give the treatment, we did not figure out that they do have it or not, we do report them. That's what I told you. When we give them the tablets like doxycycline and cefixime, we do fill up a form and send it to the public health to make sure that they know that it is already being treated if it came out positive. Then the reportable disease test and provide the empiric treatment for all sexual partners of the index within 60 days. List of the cure is recommended 3 weeks after completion of the treatment with compliance of the treatment. So experiencing the symptoms or the patient with the pubertal or the pregnancy. During pregnancy, asymptomatic neonates born with the chlamydia, any other with the specific of the sexually transmitted. What are the most common complications? The first and foremost is PID, then salpingitis, infertility, ectopic pregnancy. Don't forget about infertility, endometriosis. After endometriosis, the